Good morning. It's a very great pleasure of mine to be here, and I really want to thank Kathy and Peter for inviting me. It's been a very interesting couple of months, leaving Emory after 23 years, moving myself and my belongings to California. San Francisco, it's quite a different place, so it's been kind of unsettling, but it's an exciting change. And it's my great pleasure to come back to the SCA. As some of you will remember, I was actually a president at one point. I think I'm the fourth president ago or something like that. There's Saul as president now. Before him was Steve. Before him was Chris Mora. And before Chris was me. And I'm another Canadian like Peter. Once a Canadian, always a Canadian, but I am a U.S. citizen. And as I said, I've been 23 years in Atlanta, where I came from Montreal, where I trained at McGill with Earl. So I'm one of the people that actually knows Earl very well. I spoke to Earl twice this week. Earl is in his 80s. He is as sharp and as with it as he ever was. Remembers everything with great clarity. It's kind of scary. Earl is one of the only people I've ever seen say, well, I need to do this letter. And he takes out his tape recorder and he'll dictate a perfect letter that you don't have to change, and that's it. And I'll tell you a little bit more about Earl, because that's one of my goals this morning, is to let you know something about this amazing human being who trained several generations of cardiac fellows at McGill, as well as, of course, residents. The SCA, this is a brief little graph of the history of the early membership of the SCA, starting in '79 on the far left side and going up to 2007. And I joined the SCA when I was a resident in anesthesia, which was in around 1980. And you can see the membership was less than 1,000 at that time. And this to 2007, our membership has increased slightly. We're in the kind of the 6,000 to 8,000 range, depending on the year. And the SCA was instrumental in my learning about cardiac anesthesia and post-cardiac surgical critical care. And it's really a great honor for me to be here. I'm supported by the SCA Foundation. Hopefully you all know what the SCA Foundation is. It's a kind of a separate wing of the SCA. It's a partner of the SCA that funds all the research awards and the development programs for young faculty. There's a Roizen grant and a Kaplan grant. And so it has become kind of the charitable fundraising part of the SCA, funding all these things that we've wanted to do since the society has existed, and to do even more ongoing. So certainly if you don't know about the foundation and what it does, go to the website and talk to Joyce War, who's going to stand up in the front here. Joyce is leading the foundation and can help you if you have some extra money you want to give to help develop our society. Our society's future. So this is Earl, and I came to Emory wanting to be, I came to McGill thinking I was going to do 6 months of anesthesia training, and in Canada at that time, you could become what's called a GP anesthetist. So with an internship after medical school and 6 months of anesthesia training, you could give general anesthetics in small communities where there was a need. Canada didn't have nurse anesthetists, doesn't have nurse anesthetists, so it's all physician anesthesia at that time. At McGill, I became very fond of the anesthesia training program. The leaders there, I'll mention Sally Weeks, who's an obstetric anesthesiologist, who really kind of was the one who said, Jamie, you like this and you're good at it, why don't you stay here and finish the residency? And then I met Earl as I did my cardiac rotation, and Earl was just the power of his personality, the incredible dedication he had to the work, and the interest he had in cardiac outcomes, especially ischemic outcomes at the time, because coronary bypass was really taking off around in the 70s. And he engaged me in his research, and in my final year of training at McGill, I spent the whole year really with Earl, both in the operating room and the intensive care unit. Now, for those of you who don't know much about Earl, in addition to his amazing accomplishments, which I'll tell you a little about, Earl is legally blind. He developed macular degeneration, which he became aware of around the age 20 as he was in his studies at undergrad. And he went through medical school and training losing his vision. And he rose to the rank of leader of cardiac anesthesia at McGill. He became a chair in Ottawa. His accomplishments have all been done legally blind. And the reason I tell you that now is that a lot of what Earl accomplished was because of his partner, Mary. Earl and Mary, you would see together everywhere. Mary was his eyes. She would read to him. She would set things up for him. She would, of course, arrange his travel, go with him. Earl was incredibly dedicated to what he did. He would read all the time. He developed a computer program in conjunction with the Canadian Institute for the Blind, one of the first physicians to work with them in that regard, so that he could actually, with his peripheral vision, use a computer screen. But he was legally blind. He always gave anesthesia with what we called a technician at the time, or a resident. And he was a physician that anesthesiologists chose to give their anesthesia. So the vision wasn't an issue. He could do any block. It was all by feel. He could put in arterial lines and IVs that nobody else could do. He was just an incredibly accomplished individual. So he finished medical school just the year after I was born. He did an internship in Connecticut, trained at McGill, and then he went on faculty at McGill University and was giving cardiac anesthesia in the late 50s and 60s. Now, I don't know if you guys have read much about what was going on in the 50s and 60s, but it was pretty scary. It was the early days of cardiopulmonary bypass. It was the early days of intensive care, the early days of safe blood transfusion. Mortality was pretty high, and the only people that came to cardiac surgery were dying. They were the people that just could not be managed medically. So you really took consummate physicians, anesthesiologists, and surgeons to bring people through these procedures. He was chief at McGill in cardiac anesthesia until 1988, and then he moved to Ottawa, which was about 200 miles down the road, to become chair of anesthesia there for almost 10 years. He took an interest in simulation after he saw simulation firsthand at Harvard and made that one of his major goals of his chairmanship. And as a result of his efforts in fundraising and working with the university, set up a very impressive simulation center, which I visited. And this was the year after he stepped down as chair. I should say also that Earl has continued to stay engaged in the department. I did mention he's in his 80s. He is this year still organized the visiting professor program for the University of Ottawa. So that's the kind of guy he is. He's past president of the SCA, one of the first presidents. He's past president of the Canadian Anaesthetist Society. He's received the first Distinguished Service Award from the SCA and the Gold Medal, which is the highest level of achievement for the Canadian Anaesthetist Society. These are two articles that got Earl on his career, on the way to his leadership career in cardiac anesthesia. First an article in the Canadian Journal, and then an article a few years later in Anesthesiology on anesthetic management of patients undergoing coronary revascularization. But this was not the revascularization that you and I know. This was a revascularization called the Weinberg procedure. Now, when you say Weinberg, a lot of people kind of chuckle and say, oh, what a crackpot that guy was. He was probably a bit of a crackpot, but he was brilliant. He decided, from his research and his knowledge in the 1940s with animal experimentation, that you could dissect the internal mammary out and revascularize an ischemic myocardium with the internal mammary artery. The only thing that's different from what we do now is that he tunneled it into the myocardium and let it grow new collaterals. So this is a diagram from one of his articles, and this is the native coronary arteriole and the microvasculature here. Going across the screen are the myofibrils of the heart. These are little sinusoids which occur in the heart. And then he's got a diagram of the internal mammary artery coming in here. He tied off the end of it, and he made little holes in it, and the idea was that the blood would go into the sinusoids and eventually develop collaterals. And he was considered, this was very controversial, most people thought it was a hoax, but in 1950 he did the first patient. He was really the only guy doing this in the 1950s, and towards the end of the 50s his anesthesiologist was Earl. And in 1958 coronary angiography became possible, and when a series of these procedures, these patients who had undergone the Weinberg procedure were studied, about half of them had patent IMA with collaterals going into the myocardium. And there's a variety of series that he published showing patients with coronary disease, especially with severe coronary disease, growing these collaterals, taking away their symptoms, and the patients living 7 to 10 years or longer after the procedure without their angina and without heart failure. So it did work, but as Earl said, it was just a shame that he didn't think of grafting it onto the coronary, because that was, of course, what became the procedure. So in Earl's article in Anesthesiology in 1970, he had this table, which was the revascularization procedures of the heart. And you can read down and see what the choice was in 1970. That's not very long ago. The left internal mammary tunneled into the myocardium. The right internal mammary tunneled. The gastroepiploic, Dr. Weinberg harvested that when the mammaries weren't usable. Just epicardiectomy, which is almost, you might call that a sham procedure. A free-omental graft, putting the omentum around the myocardium. And then at a distant 5, actually doing what became the standard of choice for a standard of care for coronary artery disease. So it was in this setting that Earl was giving anesthesia. So this was not done on pump. These were patients with either severe exertional angina or rest angina who had exhausted medical management, and they were brought into the operating room, and they had their myocardium, their heart exposed through a sternotomy, and they had an internal mammary artery harvested and tunneled into their myocardium. Did that make them better right away? No, it did not. So this is a table from Earl's study, Earl's paper in anesthesiology, just looking at angina 1 and angina 2. So angina 1 would be angina, exertional angina, and angina 2 would be angina at rest. And the bottom here shows the deaths, and he's got a first series, a second series based on time. Sorry, I'll get my pointer up. So 85 patients in this first series with and 168 in the second series, and then this is 54 patients. They were the most recent patients. These are patients with exertional angina, 0 mortality in the last 50 patients he had done with exertional angina, and only 1 patient or a 4% mortality in patients with rest angina in the most recent ones that he did in the late 1960s. So doing this procedure and giving care for these patients, you can imagine the difficulties. This was also before opioid anesthesia. In 1970s, of course, this is when Dr. Weinberg's procedure was largely abandoned, and we began doing coronary bypass grafting. And it's also the era of the development of the synthetic opioids, fentanyl, sufentanil, alfentanil, and others. And Earl took this very seriously, having to give anesthesia with nitrous oxide, cyclopropane, meperidine, halothane, all these early drugs, and took up the battle with high-dose opioid. And when I joined the McGill program, Earl was studying loading doses and infusions of very high doses of opioids to try to provide anesthesia. And what was, of course, happening was that the patients were, because the procedure was so good in the 1970s, coronary bypass, then very many more patients became eligible, and the patients were healthier. And in fact, these very stable anesthetics that didn't depress the heart, these high-dose opioids, were really not necessary as the patients became, there was a larger population. And then the newer anesthetic vapors were introduced. Now this is a graph from Earl's paper in Anesthesia and Analgesia in '83, kind of a summary of all of his studies using high-dose opioids. And what this graph shows is on the x-axis here is the I'm having trouble getting my pointer. Here you go. Is stress periods. So this is intubation, skin incision, sternotomy, and aortic dissection going from left to right. And on the y-axis is plasma fentanyl concentration. And what I've circled in the yellow columns is the plasma levels in patients who responded to these stress periods. And this figure illustrates that even with very high plasma levels of fentanyl, you still have patients who respond to stress with tachycardia and hypertension. So one of the things that Earl learned, along with others at this time, was that even massive doses of opioids are not anesthetics. And that's illustrated in this. This is not Earl, although Rick Hall's another Canadian. There's similar graphs for fentanyl and the other opioids showing the percent of MAC reduction with high-dose opioid. And even if you get to very high doses, plasma levels of sufentanil that you would be unlikely to achieve in clinical anesthesia, you still only have 70% MAC reduction, meaning that some patients will still respond. And so as a result of this knowledge, Earl and others began to move back towards opioids, and that was one of the studies that I did with Earl, and this was published in '94, comparing, this is an amazing study that Earl helped design, a randomized double-blind trial. Everybody had an anesthesia induced with sufentanil, 5 mics per kilo, and then we had blinded vaporizers and blinded syringes. And we had a protocol where if we anticipated stress or saw stress, as in a hemodynamic change, we gave a syringe and we turned up the vaporizer, not knowing which one was going to be active. It was kind of a cool thing to do. This was really just a pre-bypass study, and what we showed is shown in this graph here. The colored line is the sufentanil patients. The two non-colored lines are patients who had active agents in the vaporizers and just saline in the syringes. And the hemodynamics were pretty comparable. The incidence of ischemia and CK release were comparable, and we concluded that opioids result in slightly higher pressures and more tachycardia, but all three techniques are safe. So this was the kind of environment that I came into at McGill with Earl. And then when Earl left McGill and went to Ottawa, worked there for 10 years and retired, Earl was nominated and received the Order of Canada. Now, I looked for an equivalent American civilian honor, and I was lost. There are huge numbers of governmental, military and non-military awards. I couldn't come up with a comparable one for you for the U.S., but certainly this is the highest level of civilian award in Canada, and the criteria are that it recognizes the achievement of outstanding merit or distinguished service by Canadians who made a major difference to Canada through lifelong contributions. So this is who this lecture is named for, Earl, and I just wanted you to know a little bit about this guy. And I'm going to conclude with a little vignette that I've told a few people that many of you, I'm sure, have not heard. As Earl's wife and longtime partner and supporter, Mary, began to develop the early stages of Alzheimer's, Mary was, of course, Earl's guide, and she would drive him around. Remember, they moved to Ottawa, having lived in Montreal for about 30, 40 years. They moved to Ottawa. He became chair there. They bought a house, and Mary was the chauffeur. As she began to develop some Alzheimer's, she started to get lost when she was driving. So Earl, who is legally blind, who did not grow up in Ottawa, had a compass installed in the car. And when they went, Earl would ask Mary what buildings they were passing, what streets they were on, and what direction they were going in. And Earl would navigate. That's quite a GPS. So it really is my great honor to be giving this lecture in honor of Earl. He wishes he could be here. He sends his greetings to all. And he's just an outstanding human being who I've been very lucky to have in my life. So let's get on to some of the things that I wanted to talk to you about other than Earl. But I really wanted to tell you about Earl more than anything. So as Kathy mentioned, at McGill, I got involved with cardiac anesthesia and also in postoperative critical care. And I've really made that combination my life at McGill, at Emory, and now at UCSF. And I really do think that cardiac care after surgery is a natural partnership with intraoperative care by the anesthesiologist. And I just want to thank all these folks who have helped me along the way over the last 30 years. My cardiac anesthesiology colleagues at Emory and ICU colleagues have actually allowed me to do this. The cardiac ICU nurses at Emory, I am convinced that if you look at ICU nurses in the hospital, the best ones are in the cardiac ICUs. They're engaged, excited, interested. They love the physiology just the way we do. And then all the years of incredibly good residents and cardiac fellows at Emory. I'm sure most of you know that Emory has trained between 6 and 12 fellows every year since I was there in 1990. And I always see a number of them at this meeting. So my training at McGill included 6 months of surgical ICU during my 4 years of residency and my final year with Earl, where I did a combination of OR and ICU for pretty well the whole year. I didn't do an ICU fellowship. ICU fellowships were relatively new at the time. I could have, but I didn't. I wanted to do cardiac. I went to Oxford and worked with Pierre Foy and did some lab research. And then I came back to McGill for 5 years. And the way we did our cardiac critical care was it was a 6-bed unit tacked onto the recovery room. And it was just down the hall from the operating room, which was very convenient. And in addition to working there pretty well full-time, I also had 2, actually that says months, it should have been weeks, in the medical ICU, 2 to 4 weeks per year for the time that I was there. When I came to Emory, I came to join Don Finlayson, who was the chief of the ICU at Emory, another Canadian. And then he left after the first year and a half, and I became the ICU director. And apart from a few short periods, that's really what I've done since 1990. And in addition, I set up the critical care fellowship at Emory. And in order to do that, we had to set up another multidisciplinary ICU service for the surgical ICU. So that's really been my life. And I really have to say that I like the ICU not only because it's interesting, a continuation of the physiology that we all know about in the operating room, and I continue to have the interaction with the surgeon and the cardiologist, but I really wanted to be a general practitioner way back when, and I really enjoy interacting with the patients and their families, and the ICU affords my ability to do that. And the other thing that the ICU lets me do, which is very, very satisfying, is interact with physician specialists from all over the hospital. So when we have a critically ill patient in the ICU that has different organ dysfunctions or needs particular procedures, I'm there, I meet the infectious disease doctors, I meet the interventional radiologists, and it really makes me feel much more a part of the medical institution. And there's a payback to the department because, of course, they recognize that anesthesiology is a leader within the hospital in providing patient care, not just in the operating room providing anesthesia. What have I learned in 30 years of caring for the patient? Well, we have to remember that the cardiac ICU is essentially the recovery room for cardiac surgery patients. And just as we are involved in the recovery room and we expect the surgeons to be immediately available and come into the recovery room to deal with immediate post-op problems, we need to expect the same thing in the cardiac ICU. The anesthesiologist caring for the patient is the guy who determines how the patient will wake up short of serious complications, and the surgeon needs to be involved as well. Fast-track recovery. Everybody knows what fast-track is. That's the patient who does well in the operating room, and there's no reason to keep the patient on life support, on a ventilator and sedated. Fast-track recovery is kind of critical care light, if you like. It's certainly true that patients who you think are on the fast track can fall off the fast track very quickly and become complicated and become as sick as anybody else. But most of the patients who recover uneventfully from cardiac surgery, we do it just a little slower than our other patients because of concerns for bleeding and arrhythmias, but it's really fairly straightforward, and it's very much a continuation of what your care is in the operating room. So this is a slide from Chong, published from Great Britain 20 years ago, in an intensive care setting in Great Britain where they were canceling patients because of the inability to have ICU beds. to take care of their cardiac surgical patients. So in the green columns is the percentage of patients still intubated, and each data point along the x-axis is hours after surgery. And that was with their regular ICU. So what they did was they set up a cardiac anesthesia-run recovery area, an acute recovery area. And in the yellow columns are the percentage of patients still intubated in successive hours after heart surgery. Same institution, same surgeons, same operations. And you can see by 3 hours, 20% were still intubated. And as they go on to 12 hours, they're down to about 5%. So it is possible to care for postoperative cardiac surgical patients. Now, this is, again, 20 years ago. The patients weren't as old and sick as they are now. But to rapidly recover patients just as we are used to doing in the recovery room. And we are the right people to do that because we know what operation they've had. We've got the interaction with the surgeon, and that's what we're trained to do. Our residency trains us to recover patients from anesthesia. And so a majority of straightforward cardiac procedures, we are the right ones to be managing that. If the setting is an ICU 3 floors away, and the ICU doesn't allow for the anesthesiologist to be involved, that's a different physical and political problem, but medically, we are the ones that are most appropriate for this kind of patient. Now, this is a graph also from Great Britain looking at the proportion of patients over the age of 70 presenting for cardiac surgery, going from 1990 on the left-hand side to 2001 on the right-hand side. So this is relatively old data, but it still shows the same trend that I mentioned, and the graph continues to go upwards to the right. The percentage of patients over the age of 70 was about 18% in 1990 and is at about 38% in 2001. There are a number of publications on coronary bypass and aortic valve surgery in the octogenarian. And what these publications all show is that these older patients have more comorbidities, of course, than their younger cohorts. Older, more comorbidities, sicker, they're frail. This is now a categorization used in preoperative evaluation and in geriatric medicine, a frailty index, patients who are just kind of frail with major organ system dysfunction, and when you put them through the stress of a big operation, they have more trouble. They need to be ventilated longer, they develop more organ dysfunctions. They require true multidisciplinary critical care because they don't just have cardiac problems, they don't just need to be ventilated, but they have all the attendant problems that go on with critical care. Infections, renal dysfunction, hepatic dysfunction, wasting, and these are the realm not of the cardiac anesthesiologist, these are the realm of the critical care physician. And so in order to care for these people, I think that you need more than the 1 month that you get as a cardiac anesthesia fellow. The other thing is that the surgeon needs to stay engaged in the care. And I think this is one of the unique things about the partnership between the cardiac anesthesiologist and the cardiac surgeon. This is the kind of traditional view of how ICUs function. We have the open unit on the left, which is the patient comes in under the primary doctor, and if you have an 18-bed unit, you might have 18 primary doctors and 18 ways of doing things. So that's the traditional open ICU. And the only doctors that come to see the patient are by invitation from the primary physician. On the far right is the closed unit, and that's the ICU where if you're at Columbia University and Dr. Sladen is running your ICU, and I don't know if you actually do this, Rob, but when you come into the unit, your little blue card that has your name on it changes, and your primary doctor is now Dr. Sladen, and your admitting doctor comes off that primary card. So that all the patients in the ICU are taken care of by the critical care team, and even the admitting physician has to go through the critical care team in order to write orders and make suggestions. So that's the closed unit. You know how popular that idea is with surgeons. Okay, so that doesn't really work with surgeons in general that well, and it doesn't work with cardiac surgeons because cardiac surgeons need to stay engaged with their patients, and they have kind of a special relationship that's a little different than many other surgeons. And so most units have what we call this semi-closed or semi-open structure, where instead of a free-for-all and every patient having a different doctor and a different way of doing things, there is an ICU team. The ICU team may see everybody. The ICU team may coordinate all the orders, but it's a little fuzzy about the edges about how it exactly works. Which system is better? Open, closed, semi-closed? There's lots of articles about this, and I'm not going to go through this literature. I think that it suffices to say that we know that having an intensive care involved in running an ICU and managing the patients, an intensive care team, the majority of studies show that that improves outcome. It reduces length of stay, it reduces transfusions, it reduces complications if there's a critical care team involved. But the differences are myriad. The differences between units, the political implications, and just how engaged the ICU team is. Do all the orders go through the team, or do some of the orders go through the team? And this is an article published just this year in Chest with a very long abstract that I'm not going to read to you, which essentially says the units are so different, the research is so difficult to interpret that we really don't know, and if you know one ICU, you know one ICU. You have to look at all the considerations. So let's go back to the cardiac ICU. What is the literature on cardiac ICU management? That intensivists or cardiac anesthesiologists actually make a difference in cardiac ICUs. This is the literature. Unfortunately, there's very few studies. I guess where this comes from. It's a Canadian theme today, right? So this is a Canadian study. This comes from the University of Manitoba in Winnipeg. And the authors are a mix of, if you can read the details here, Department of Hematology and Medical Oncology, as well as cardiac surgery and critical care. And one of the authors is actually a critical care hematologist. Two of the authors are critical care anesthesiologists, and the others are critical care cardiac surgeons, two of whom do just critical care. They don't operate. And one of the authors is Joel Zivit, who is actually my colleague, or my former colleague at Emory, who came to Emory a couple of years ago. And I asked Joel if he thought this was a good study, and he said it was. So that's why I'm presenting it to you. And essentially what these folks did was they looked at a retrospective period around 2000, I think it was 2005 and 6, about 1,000 patients that were managed in a traditional surgical ICU, and then they opened a cardiac surgical ICU with cardiac anesthesiologists during the day and also a nighttime intensivist. I think this is a little blurry, but I'll go through this with you. So in the early phase, the first phase, the patients were transferred from the operating room to an ICU where there's an in-house certified intensivist during the day, and at night there's an in-house resident, and at night there's the resident is in the house, and there's an intensivist that will be able to come back and certainly be called for problems. And this is a surgical ICU with cardiac patients in it. In the next phase, the patients came from the operating room, and this is like a little fast track here, and they're managed by an in-house cardiac anesthesiologist here, but there's also an in-house certified intensivist in the same unit, and at nighttime there's an in-house certified intensivist. Okay? So this was the model. It was propensity matched. They matched up the patients. They looked at it over 4 years. And this is the main figure from their study showing the main difference. And this is showing a difference in red cell, platelets, and plasma transfusion, more done in the general surgical ICU where there was no cardiac anesthesiologist during the day and no in-house intensivist at night. They also found that the patients were ventilated for some hours less when they were managed by the cardiac anesthesiologist. And they also found that the length of stay in the ICU was shorter when the patients were managed by the cardiac anesthesiologist and the intensivist in a dedicated cardiac ICU. And this is one study, prospective, retrospective, about 1,000 patients, but it certainly points to some benefits of having the cardiac anesthesiologist engaged in knowing what goes on in the operating room, communicating with the surgeon, and managing the patients as you and I would. How else is an ICU, the cardiac ICU, different from other ICUs? Well, in the MICU, the patients get sick on their own and come in with some terrible problem, usually. Okay? In a SICU, the surgeon did it. The patient walked into the surgeon's office most times. Now, there are emergencies, of course. But the patient walked in and the surgeon said, yeah, I can make you better. And then in the ICU, when the patient's not doing well, the surgeon's sitting there looking at the patient saying, I remember this patient talking to me, and there he is on a ventilator and on dialysis because of the operation that did not make him better. And then there's the cardiac surgeon just as a category of human beings. And I don't know if I need to say anything to you about that. We all work with them. Cardiac surgeons are a different breed. They go through an incredibly intensive training. They're usually very individualistic. One of my colleagues used to say cardiac surgeons all hate each other. I don't know that that's true. But they are certainly very competitive, aggressive individuals, kind of at the peak of the surgical mentality. And it takes special kinds of individuals to deal with cardiac surgeons, and that's us, because we deal with it all the time. Most surgeons do procedures where the operative mortality is very low, in the less than 1% range, most procedures. While the only common cardiac surgical procedure with that low a mortality is an elective CABG in a healthy young patient. Pretty well every other cardiac surgical procedure has a mortality measured in 2, 3, 5, 9, 10, 15%, depending on the patient. So these patients will die if the operation doesn't go well or there's a poor judgment of patient. And this is different. This is different from other ICU-type patients. And we all know that as patients warm up and as patients wake up and as patients get sedation, that our cardiac surgical patients have acute changes in their cardiovascular status that can't be dealt with on medical time. You got to be there looking at it, you got to be there with your syringes, and you got to be aggressive in treating issues in these patients, or they develop myocardial failure, right heart failure, strokes, and renal failure just as a result of delayed or inadequate speed of resuscitation. So, yes, these things occur in other ICUs, but they're a regular occurrence in the cardiac ICU. They're different. And then finally, most serious complications in the acute setting in the cardiac surgical ICU involve a cardiac surgeon to deal with it. Tamponade, bleeding, serious dysrhythmias as a result of ischemia. So this is how the CT-ICU is different, and the theme I'm making here is that not only do we need to be there, does the intensivist, ideally the intensivist familiar with the cardiac surgical patient, which is the cardiac anesthesiologist, needs to be there dealing with the acute episodes, but so does the surgeon. So we have to work in a surgical setting where we expect the surgeon to be engaged in care. We expect the surgeon to be telling us what he thinks. This is not the closed ICU. This is the semi-open model of ICU care. And then there's the issue of trust, okay? Cardiac surgeons do their operation and they expect to be called 24/7 for problems. This is the same to a degree with all other surgeons, but very much so with the cardiac surgeon. They don't just drop the patient off and expect everything to be taken care of by somebody else. The ICU care provider has to understand this, has to understand the physiology of the patient, has to speak the same language for the cardiac surgeon to trust him. And cardiac surgeons are made very uncomfortable by frequent shift changes. When they have the doctor they know, Dr. Sladen, during the day, and then all of a sudden this outsider from Atlanta comes up, Ramsay, and they don't know me. And when the surgeon brings the patient out and he saw me in the afternoon and sees somebody else at 8 o'clock at night. So this is something that you have to work on with your surgeons to build the trust so that they understand how we staff an ICU so that people can live a life and not want to leave. So the cardiac surgical ICU is different, the setting is different, the cardiac surgeon is different, and the relationship that we have with them is a special one. Now, in 2004, I was asked to do an editorial by Lee Fleischer for the Red Journal. This was a pro-con. Stuart Weiss wrote that cardiac anesthesiologists should run post-op ICUs, and I took the point of view that cardiac anesthesiologists should not run cardiac ICUs. At the time, I was a cardiac anesthesiologist running a cardiac ICU. And the real point that I made at that time, and as I still make the point, and that's why I'm talking to you today, is that we are the logical caregivers in the post-op period. For fast-track patients, we are still the logical caregivers. But when it comes to ICU, when it comes to the ever-increasing percentage of patients that develop true critical illness, then a cardiac anesthesia fellowship with 1 month of ICU doesn't really prepare you for that. And if you're training people to work in the cardiac ICU, they need more than that. So I'm not saying we shouldn't do it, I'm saying we need more. And the more, in 2013, is doing a dual fellowship, doing a fellowship in cardiac anesthesia and a fellowship in critical care. So these next two slides are from the ACGME. This one is looking at the number of cardiac anesthesia fellowships and filled positions. And so from 2007 here, where we started, there were just 4 accredited fellowships on the first go-round and 15 filled positions in ACGME-approved cardiac fellowships. And in the latest go-round this year, we have 58 accredited fellowships and 174 fellows in training in cardiac anesthesia. I'd say that's a pretty amazing achievement, considering how it's just 5 years ago we had so few. And I'm sure you all know that the group that made this happen is before you today. It's the Society of Cardiovascular Anesthesiologists with the leadership of Alan Schwartz and a variety of others that actually made this appeal and made accreditation happen. So 174 cardiac anesthesia fellows after 6 years. Okay? This is a different way of expressing it because this is looking at all critical care fellows in all kinds of training. And this is looking at internal medicine critical care fellows, pediatrics, internal medicine, and surgery and anesthesia. And the little column to the left in blue is anesthesia. So these are the number of fellows in training in critical care programs in the U.S., the total number of filled positions. And in 2003 and 2004, 10 years ago, we had 50, I think that says 59, I don't have my glasses on, 59, thank you, 59 anesthesia critical care fellows, and 10 years later, we have 155, almost as many as we have cardiac anesthesia fellows. And this is with critical care being, of course, going far before 2003. The gratifying thing here, if you look at that and say, oh God, we're totally outnumbered, which we are, but the gratifying thing here is that we've tripled in a decade. And if you look in particular in the last, from 2010, 83, to 2013, 155, that's a really big increase. So as a result of circumstances, some of which we understand, some of which we don't, those of which we understand are that the American Society of Anesthesiologists has been promoting critical care more. We've incorporated more critical care training into residency programs, and there are jobs, and there's luminaries in our field that are attracting bright young people to do these fellowships. We are making inroads. But think about the United States with 300 million people in it, and think about 150 cardiac anesthesia fellows, or 170, and 150 anesthesia critical care. It ain't enough. Okay, there just aren't enough. And so this comes back to who should be running the cardiac surgical ICU. And I would tell you that short of a critical care fellowship, a cardiac anesthesia fellow is the next best choice. I personally think that a cardiac anesthesia trained fellow who enjoys and is interested in postoperative care, who spends time in the ICU, is as good as and possibly better than a non-cardiac trained person who has done just critical care. And that's a slightly controversial statement, but that's where I am on it. So to train in adult cardiac anesthesia, you have to do 7 months of clinical operating room time, and this is the current requirements. 1 month of ICU, which I call a taste of ICU. 2 months of electives. TE training is defined by our society and the ASC. There's no certification, but that's coming before too long, I would expect. The SCA, a society devoted to cardiac anesthesia, cardiac track, And in our journal, Anesthesia and Analgesia, we have our own cardiac section, cardiac editor. So we are definitely a subspecialty of anesthesia with very definite training requirements. We differ from critical care anesthesiology in that the ABA requires training in your residency, but if you want to be a critical care specialist, you have to do a 12-month fellowship, which includes 9 clinical months in ICUs. There is a subspecialty examination. There is a subspecialty organization of critical care anesthesiologists. I would say to you that those working in cardiac ICUs, their subspecialty organization is more the SCA than the ASCCA. We have a critical care track at the ASA, and we also have a section of critical care in anesthesia and analgesia. So if we're not going to do this, who are our competitors who are going to work in the ICU and take care of the cardiac patients along with the cardiac surgeons? I'm trying to make my slides advance here. Sorry. Sometimes it sticks. There we are. So I think the ideal CT ICU intensivist is somebody who is trained in cardiac anesthesia and in critical care. And I think the time has come for us to promote this idea in our specialty. How much training after residency is tolerable? Are we going to be able to combine these fellowships in less than 2 years? I don't think we want to send that message out. Do we want to send that message to surgeons and internists who all train longer than we do and say that, no, we don't need 2 years to train in intensive care and cardiac. We'll do it in 18 months. Or we'll do it in 1 year. We can't do it. And I don't physically think it's possible to do it. Do you think that a cardiac anesthesia training you can replace some of those months of training with critical care and be just as good at cardiac? So I think in an integrated 2 years makes a lot more sense than trying to constrict the training. Who are our competitors? Who want these jobs? And there's a lot more of them than there are of us. Other intensivists? Hospitalists? If you ask a hospitalist if he can do something, what does he say? Yes. Okay? Doesn't matter what it is. Can you take up this service? We have a problem over here. Can you fix this? Yes. We'll hire more hospitalists. So they're out there, and there's hospitalists working in ICUs for sure. Cardiothoracic surgeons. Rob and I were talking about this yesterday. As surgeons, some cardiac surgeons are better than others. Some aren't that great, and some are getting older and not as good as what they used to do. And those surgeons are gravitating to post-cardiac surgical critical care. Cardiologists. I'll show you a couple of interesting slides here. The whole idea that maybe you can create a cardiovascular intensivist. So this is 2 titles from 2 articles recently published. One is from the Journal of Thoracic and Cardiovascular Surgery. Nevin Katz is an older surgeon at Baltimore at Johns Hopkins. Is it time for certification in cardiothoracic critical care? And he's not talking about us, although he does mention us. But he's talking about surgeons. Should surgeons in their training, cardiothoracic surgeons, get certification in critical care? Should there be some new certification within the training or within the American Board of Thoracic Surgery? And perhaps even more disturbing, this is from Circulation last year, evolution of critical care cardiology. So this is a statement saying that we need to create critical care cardiologists, cardiovascular specialists, because of the change in cardiac care non-surgical, but they include surgery. Now, to give benefit to Dr. Katz, to give credit to Dr. Katz, he does include us. The recognition of need by CT surgeons is at least 10 years old. There's a cardiothoracic surgical critical care medicine conference that was begun in Washington, D.C. about 10 years ago, created by the Foundation for the Advancement of Cardiothoracic Surgical Critical Care Medicine, run by mostly surgeons and critical care nurses, but there are anesthesiologists that have presented at that meeting. Then an editorial appeared 5 years ago, recognition of this course by the American Board of Thoracic Surgery, endorsement by the 2 big thoracic surgical organizations, and then a big article last year talking about a curriculum for critical care medicine within surgery. And then this editorial that I showed you by Dr. Katz. The Journal of Cardiothoracic Surgery and Vascular Surgery now has an editor just for perioperative care. So the surgeons are recognizing the need, and they're saying, we can do it. There aren't enough of them, and they really don't have enough to do it properly. But this is something you should read here. This is tacked on at the end of Dr. Katz's editorial. Cardiothoracic surgeons recognize that their colleagues in cardiothoracic anesthesiologists, us, are in a position to share the surgeon's unique understanding of cardiothoracic operations, the associated physiologic changes, and potential complications. In many centers, and you know which ones those are, cardiovascular or cardiothoracic anesthesiologists have an important role in the multidisciplinary team. It therefore seems appropriate, as the American Board of Thoracic Surgery develops its approach to certification for surgeons, that consideration be given to inclusion of our cardiac anesthesiology colleagues. So the surgeons know we're there for them, but they at the same time want to develop this specialization. In terms of what are they proposing for training, there's no dedicated rotations in critical care required in cardiothoracic surgery. What he says, it's important to address several pathways to get to certification, but he doesn't talk about increasing the duration of training, and it's still kind of a work in progress from the surgeons. What about the cardiologists? Circulation article that I quoted, I showed you the title of, addresses predominantly the medical ICU, but it recognizes that cardiology patients now, just like surgical patients, are older with more comorbidities, they're undergoing bigger procedures, and there are many of them requiring multi-system critical care. And then they go on to say that with new assist devices, the borders between the CCU and the cardiothoracic ICU are getting blurred. So that sounds to me like they're saying we can go and work in the surgical ICU with you. This is a figure from actually from Duke that a different Dr. Katz, talking about the cardiologist in critical care, has shown. And he looks at the diagnosis and procedure, the odds of patients who are leaving a coronary care unit have these diagnoses or procedures. And what he's showing here is that the majority of these patients are having problems like sepsis and liver failure, and instead of getting cardiac procedures, they're getting bronchoscopy and ventilation. They sound like just plain old critical care patients in CCUs. And he's got this nice little color diagram on the history of CCUs, showing that in the early stage, CCUs were really there for rapid resuscitation. The next stage was for preventative intervention in arrhythmias and post-op MI care. And now, in the current era, the CCU needs to be able to provide comprehensive critical care. So the cardiologists are now recognizing the need for this. So currently, in your 3 years of training to be a cardiovascular specialist in medicine, i.e. to be a cardiologist, in the 3 core years of cardiology training, there's no requirement for ICU. They get exposed to sick patients, but they don't do real ICU rotations. So what they're proposing is to maintain this current requirement for 3 years in cardiovascular medicine, but adding a year to make it a 4-year training program that can either be 3 years of cardiovascular medicine and a regular critical care fellowship, or integrating critical care with a cardiac focus within that cardiology training. So the cardiologists are getting in and they're saying we can do it. And they specifically talk about rotations in cardiac surgical ICU. There's no provision for just doing critical care cardiology. And there's no suggestion of anesthesiologists in that big, long circulation article. We're not mentioned. So the competition is out there. To where does that leave us in 2013? Cardiac surgeons and cardiologists are moving to encompass certification within their domains. We are few and far between, 150 critical care fellows, 170 cardiac anesthesia fellows. Those who've got both fellowships are even fewer and far between. So what I'm submitting to you today is that we need to recognize that this is our natural domain, the post-cardiac surgical ICU. And as a specialty, we need to recognize it takes more than a year to be both a critical care specialist and a cardiac anesthesiologist. And we need to promote this as people consider anesthesiology. We need to encourage our specialty to recognize the value. We need to promote the specialty track training from the beginning. There are a number of residencies innovative programs, according to the ACGME, that's the terminology used. There's a number of programs where a resident can be accepted into a combined training program in anesthesiology and critical care. And critical care is incorporated into the residency earlier on than in just doing 1 year at the end. Maybe we can do something like that with cardiac. Maybe we can actually create an integrated 2-year training program where our residents do a mix of critical care and cardiac throughout the 2 years. And they become board certified in both subspecialties, and they're the true cardiac specialist in our domain. And we need to work with our surgeons and our cardiology colleagues to make sure that they recognize our role historically, our current role, and the future that we have to contribute. And with that, I'd like to conclude and thank you for inviting me for your lecture.